Good evening all. I welcome you all today for 20th Masterclass lecture on interpretation of coagulation report case-based discussion. Teacher for today's meeting is Dr. Cecil Ruben Ross, Professor Medicine and Hematology, St. John's Medical College Hospital, Bangalore. Over to you, sir.
Okay, thank you. Thank you for that introduction. Okay, so what we are talking today is interpretation of coagulation report, case-based discussion. So what I will do is I will start with basically a bit of coagulation cascade. I think what you should know, the basics, easy to understand. Then the importance of history and the context in which the report has to be interpreted. You have to know the cause of prolonged various plasma clotting times, and then we'll top it up with case discussions. The total duration will be about some 40-45 minutes, and 15 minutes we can keep for discussions or whatever questions are there. All right. So normally, when you look at hemostasis, 4 major systems are involved, and that is the basis of all the screening tests that you do in patients with coagulation disorder. The first is the vessel wall phase, the vascular phase, where the important screening test to do is bleeding time. The endothelium, collagen, and the vascular contraction, these are all the important factors that you get when there is a vessel wall injury. The next stage is the platelet phase. The platelet phase, the important screening tests here are platelet count and morphology. They are like an internal band-aid. Whereas there is a vessel wall injury, they just go and put a band-aid there so that bleeding stops. They are internal band-aids. So you have to do a platelet count and platelet morphology. The next is the coagulation phase. In the coagulation phase, you do prothrombin time, activate partial thromboplastin time, and thrombin time. These are basic tests that we do normally in a screening for coagulation phase. The last phase is the fibrinolysis, where normally after the clot is formed, the body's mechanism is to dissolve the clot and establish the patency of the vessel. And therefore, normally there is fibrinolysis that takes place. And important in that is also factor 13. And therefore, you have to always, in all screening tests in a patient with coagulation disorder, you must also look or assess for factor 13 deficiency. So these are the main 4 hemostatic phases that are involved and the basis of the screening test. It's important for all the residents to know that when you actually send a blood sample for any coagulation process, there should be minimally circulatory stasis. There must be a clean venipuncture, because if there is multiple punctures and then you send the blood for coagulant test in a PT tube, in a blue top tube, then what happens? The tissue factor that gets into the needle gets into the thing, and normally the prothrombin time or the partial thromboplastin time, which have otherwise been prolonged, gets activated in the tube only and they get shortened. Therefore, there should be a clean venipuncture. There should be a proper anticoagulant. That is, normally we use Vacutainer tubes and the blue top tube, and the proportion of blood is exactly 9:1 because all the tests are calibrated at that ratio. And normally you should send the tube immediately to the lab where they will process for a platelet for plasma, and then they will do all the coagulation tests based on the platelet for plasma. And so also you have to remember also the effect of stress, pregnancy, crying in children, and so on and so forth, and the effect of drugs. Another important thing that you have to look also is especially in patients with coronary heart disease or patients with high hematocrit, the amount of plasma that is there is less. So therefore, the coagulant test will also be abnormal, because all these coagulant tests are based on the basis of normal hematocrit. So you must look at the effect of hematocrit and see the relative volume of citrate anticoagulant blood in the collection tube. So coming down to basics, you have the intrinsic pathway, the extrinsic pathway, and the common pathway. This is all you know. Now, rather than thinking about the intrinsic pathway, extrinsic pathway, and common pathway, it is better to think it of as a PTT pathway, that is the intrinsic pathway, the PT pathway, that is the extrinsic pathway, and the TT pathway as a common pathway. It's easy to remember. So normally what happens, the PTT pathway, the PT pathway both converge on X, okay, factor 10, okay, like a cross. It is like a cross, so it marks the intersection of the two. Then what happens, the factor 5 sits on the notch on the 10 and forms the factor 10A, right? Once the factor 10 is formed, it converts the prothrombin time to thrombin, and once the thrombin is formed, it converts fibrinogen to fibrin. That's how it is, clot is formed. I think this is much basic you should know. Now let us go a step a little more and look at the pathways individually. Now if you look at the PTT pathway, there is factor 10, 8, 9, 10, 11, 9, 8 and 12, 11, 9, 8 and 10. Okay, that's called tenet. Okay, now these are the PTT pathway. All right, and produces ultimately a fibrin clot. If you look at the PT pathway, the prothrombin time is only factor 7, and extrinsic pathway forms the clot ultimately. Then, once the clot is formed, when there is a vessel wall injury, there is plasminogen that normally is secreted in the body, and tissue plasmin inactivator forms plasmin, and the plasmin converts fibrin to fibrin split product and dissolve the clot. So this is normally what happens in normal hemostasis. So coming to a little bit history, what you should take, what history that you should take in a person who was suspected to have bleeding disorder. The onset of bleeding. Supposing the child, early childhood, bleeding since early childhood would suggest inherited disorder. If it occurs later on in life, it suggests an acquired disorder. Then the type of bleeding. If there's a mucosal or skin bleeding, it is usually quantitative or qualitative platelet defects or von Willebrand's disease. Supposing there's hematoma, hemarthrosis, increased bleeding from cuts, tooth sockets, you think of hemophilia coagulation factor deficiency in those sort of bleedings. Then in women, patients who have got menorrhagia, PPH, recurrent pregnancy loss, these are the specific things you should ask for in women who bleed. Then you have severity of bleeding, frequency of bleeding episodes, amount of blood loss, duration of bleeding, transient requirements, so that it will tell you how severe that bleeding was. Then of course you have to ask for in children, bleeding at time of primary dentition, puberty menorrhagia, menorrhagia at menarche, these sort of things you should ask in children. Then if there is a neonatal period, you would ask for history of delayed wound healing and bleeding from the umbilical stump. That would suggest usually factor 1 and factor 13 deficiency. Then family history of bleeding in male members in the family would suggest hemophilia disorders because of sex-linked disease. Then in South India, because there's a lot of history of consanguinity, first cousin or uncle's marriages, you normally in 80 to 90% of patients with platelet qualitative defects like thromboasthenia or factor 13 deficiency, we normally encounter. So this is something that we have to ask for always, history of consanguinity. So this I think we will not give because this is really okay. So if you have a person who has got only PT that is prolonged, okay, that basically means that it's factor 7, that's the extrinsic pathway, and factor 7 will prolong PT but not the PTT. So usually if there's bleeding, when a person has got a PTT that's prolonged, you think the person has got a factor 7 deficiency. If the person has got no bleeding and he's got PT that's prolonged, then you think patient's got a mild factor 7 deficiency, but the commonest one is warfarin, use of warfarin. So normally when you put a patient on warfarin, you look for PT and you maintain the PT in about 2.5 to 3 to see whether the person is well anticoagulated. This is only when the PT is prolonged. Okay. Now, if the PTT is prolonged, only the PTT is prolonged, then you have any of these factor 12, 11, 9 or 8. Okay, that will be prolonged. That here the PT will not be prolonged, only PTT will be normal. Remember that the factor 10 is a common pathway and affects both the PT and the PTT. All right. So this is the way you have to assess and figure out where the problem seems to be. So supposing you have a person who's got only increased APTT, that's increased activate partial thromboplastin time. If there is bleeding that is injury related, then you think whether the person has got factor 11 deficiency or mild to moderate hemophilia, that is factor 8 or factor 9 deficiency. If there is unprovoked bleeding, then you think that the person has got severe hemophilia A or B, or the person may be having acquired inhibitor or severe von Willebrand's disease. If there is no bleeding and the APT is prolonged, Then you think whether the person has got deficiency of factor 12, high molecular weight kininogen, precalcrin, lupus anticoagulant, heparin, and so on and so forth. So this is how you look at when the person has got APTT that is prolonged. When you have the APTT that is prolonged, normally it is useful to differentiate various coagulation assays by doing a mixing study. So what here happens is the patient's plasma, which is deficient, is mixed with the normal plasma, 50 to 50, 50 to 50 with normal plasma, and the coagulation assay is repeated. APTT or PT is repeated. If the mix substantially corrects the time, the PT or PTT, this means there is a factor deficiency. That means there was some factor that was present in the normal plasma, which you have supplied in the patient's plasma, and therefore the PT or the PTT has been corrected. That means it's a deficiency problem. Now, if there is no correction, when you add normal plasma, that means there must be a lupus anticoagulant or some other inhibitor like heparin or something, because you added the inhibitor. Supposing there's, let's say, an anticoagulant in the tube in the patient plasma, which inhibits the clotting plasma, which inhibits clotting in the normal plasma. If you time the incubation, that if any correction is lost within 1 hour, then most commonly it is considered the factor inhibitor. Okay. Now let me explain to you a little bit in detail. You have a patient plasma which is deficient. You add normal plasma, right? And then you do the APTT. Okay. When you do the APTT, it corrects. That means it is factor deficiency. All right. Now, supposing a person has got factor 8 inhibitor, and then you do the mixing study, it does not correct. That means there is inhibitor present. Clear? So, if the person has got factor deficient plasma, you add a normal plasma, right? And APTT corrects. That means it's a factor deficiency, either factor 8 or 1 Willebrand's. Okay. If you have a patient with factor 8 inhibitor and then you add normal plasma, it won't correct. That means there is inhibitor in that patient's plasma, right? So this is how you do. Now there's another reagent which you can have adsorbed plasma and other reagent called 8 serum. Okay. Now supposing you have factor deficient plasma and you add adsorbed plasma to that tube and it corrects. That means it is factor 8 deficiency. So it is adsorbed plasma is the source of factor 8. Similarly, if you take factor deficient plasma and you add 8 serum and it corrects, that means it's factor 9 deficient, because 8 serum is the source of factor 9. If it gets corrected by both, then it becomes factor 11 or factor 12. And depending on whether the person is bleeding, if he's bleeding, it is factor 11 deficiency. If it is not bleeding, it is factor 12 deficiency. That's how you do. So supposing same thing, if a person has got a prolonged PT alone, and then you do the same tests again, you correct with 8 serum, not corrected with adsorbed plasma, it means factor 10 deficiency. If you take 8 serum and do mixing study, not corrected with 8 serum, but corrected with adsorbed plasma, it is 5 deficiency, factor 5 deficiency. Not corrected with 8 serum, but partial correction with adsorbed plasma, it's factor 2 deficiency. So this is how simply you can do the test to figure out which deficiency the person has got. Now, supposing the person has got prolonged APTT and prolonged bleeding time, then you normally think is 1 Willebrand. So this is the picture that is got from Harrison, where you have to understand this, because the glue between, if there is a vessel wall injury, the glue between the endothelium and the platelet is a 1 Willebrand factor. All right. But the glue between platelet and platelet is fibrinogen. All right. So therefore, when there is 1 Willebrand factor deficiency, the bleeding time will be prolonged, and the bleeding will be there because there is no factor 8. So these are various types of 1 Willebrand type 1, 2, and 3, which I will not talk too much. But normally, if you have a complete absence of factor 8, less than 5%, then it's the most serious form of 1 Willebrand disease. All right. Right. So then if you have a patient who's got APTT that's increased, PT that's increased, but thrombin time is normal. It depends whether the person has got bleeding or not. If there is bleeding, then you think whether the person got afibrinogenemia or a common pathway deficiency or oral anticoagulant therapy, acquired inhibitors to 2, 5, and 10, or liver disease and DAC. If there's no bleeding or mild bleeding, then you think whether the person has got hypofibrinogenemia or mild factor deficiencies of 2, 5, and 10. So that's how you find whether the person has got APTT or PT, that is increased, but thrombin time is normal. Supposing APTT is prolonged, PT is prolonged, thrombin time is prolonged, all three times are prolonged. PT is prolonged, PTT is prolonged, thrombin time is prolonged. Then you normally get this in patients who got hypofibrinogenemia or dysfibrinogenemia, heparin therapy, liver disease, and there is systemic hypofibrinolysis. I told you when there is a clot formation, body's mechanisms to open the clot to establish the patency of the vessel. So hypofibrinolysis happens. Okay, so that time you get all these three things that are prolonged. Now, if all plasma clotting times are prolonged, PT is prolonged, APTT is prolonged, thrombin time is prolonged, and the platelet is low, that means the person may be having DAC. Then you look for FDP, D-dimer, fibrin monomer, and so on. Now, supposing you have isolated platelet count that is low, thrombocytopenia. Your PT is normal, PTT is normal, TT is normal. Okay. Then it's a totally different ball game. Then you have to think whether thrombocytopenia is pseudo versus true. And then depending on if it's true thrombocytopenia, then you have to do a marrow to differentiate whether the platelet count is low because of decreased production or increased destruction. So that's how you do a marrow, but otherwise you don't do marrow in all patients, but bleeding problem. Now, supposing the APTT, PT, TT is normal and the platelet count is normal, sometimes you get this problem. Patient is bleeding. What do you think? Anybody? PT is normal, PTT is normal, TT is normal, platelet count is normal, patient is bleeding. Post surgery, let us say. If you think whether the person has got hypothermia, is normally seen in ICU setup. That person is a hypothermic, APT and PT are run in vitro at 37 degrees centigrade. So the lab test may be in error. Okay. So the commonest thing that especially you see in surgical patients is factor 6 difference. You know what factor 6 is? There are 13 factors, right? So what is factor 6? The suture material. Okay. So if the suture is slipped off or suture is deficient there, okay, in patients who have had surgery, they will bleed and all this will be normal. Then you have to tell the surgeon that no, it's nothing wrong with hemostasis. It's not a coagulation problem. It is probably suture problem. Okay. Right. So supposing the PT, APTT, TT is normal and the platelet normal. Okay. And still the person has got a history of bleeding, then you think whether the person has got factor 13 deficiency or thrombasthenia or disorder vascular hemostasis. Something that you have to look for, because in this case, you normally would get some kind of history and then you strongly suspect, and all screening tests, you have to rule out factor 13 deficiency. And of course, thrombasthenia, you will check by doing a bleeding time normally. And of course, disorders of vascular hemostasis. Supposing the patient is asymptomatic, okay, and the PTT is prolonged. Normally, you get this kind of situation in bilateral from nephrology, where the person wants to have a kidney biopsy, and the APTT is prolonged, so they want to know what to do, because the person's got normal size kidney, has got renal failure or nephrotic range proteinuria or something like that, and then they want to do a liver kidney biopsy. So then you think that the person has got lupus anticoagulant or factor 12 deficiency or mild congenital factor deficiency. So these usually don't bleed. They are clotters, so they don't bleed. The APTT will be prolonged in them. Okay, this is person's what? Asymptomatic. Okay. So now we'll go to cases. Okay, now this case, with this little bit of background, let us say this case is a 30-year-old male, had a road traffic accident. He was seen in emergency, resuscitation with IV fluids and a lot of blood transfusions. And after stabilizing, patient has to be taken up for surgery. At that time, you find that the PT is slightly prolonged, 15 with control of 12. APTT is mildly prolonged. Common time is normal. There is thrombocytopenia. Platelet has got 51,000. What do you think? Anybody? Mild prolongation of PT, mild prolongation of PTT, thrombocytopenia 51. In otherwise normal fellow who had no history of any bleeding in the past. The road traffic accident, came to the emergency, received IV fluid, a lot of blood transfusion given, 8-10 blood transfusion given, stabilized the patient, hypotension, this, that, and the other. And now there is some laceration or bowel injury or something like that. So they have to take up for surgery. He's got fractures to be taken care of. He's got some abdominal surgeries to be taken care of. So patient is stabilized, taken surgery. So just before surgery, they have done this test. What do you think? You're called. You're the resident on duty. It is 9:30, 10 in the evening. And you're called. And these are the values. Anybody? Somebody must say something because otherwise I think I'm talking to the computer. No, this don't get intimidated. It's a simple thing. Are you listening to me, or can you hear me, or am I not audible? Usually, this is because of dilution of coagulation proteins. So, supposing you give a lot of blood, IV fluids, and so on and so forth in a massive blood transfusion, or person who's got a lot of fluids, crystalloid, resuscitation with a lot of blood transfusions. And normally, blood transfusion in this setting is whatever you get blood in the blood bank will be stored blood. So usually there will be dilution of proteins. Approximately about 10% drops will be there in coagulant proteins for every 500 ml of blood loss. So normally you would give 10 to 12 units of transfusion, and you give 10 to 12 units of transfusion, there is a 50% fall in the platelets. So this is basically a dilution problem. So you have to, what do you do in this situation? What would be your recommendation? Now you have to take a decision. Patient came in the morning. By afternoon, evening, they have resuscitated the emergency department. And these are times, plasma clotting time and platelet count which is low. And then you are the resident on duty, you are called. And your boss is not tracing. You are the resident. Okay. Nobody seems to be answering. So normally you would give about 2 to 8 units of fresh fluid plasma while the patient is being taken for surgery. Normally 1 unit of plasma FFP will increase the clotting protein by about 6% or so. So you decide how much time, how much would be the approximate plasma. Normally you would give about 1 bag per 10 kg body weight, approximately the rule of thumb. And if the platelet is 51,000, you have to remember that 1 single donor platelet or 6 random donor platelet you have to give till about, if the patient has got a platelet count of less than 50. So if you give about this 6 random donor platelet, 1 single donor platelet, assume that it will raise by about 7 to 10,000 per bag. So you can raise it about 80 to 90 and then take up the patient with surgery. All right. So that's the kind of thing that you do, and afterwards you do firefighting. Because once the surgery, whatever correction has been done, then the body's normal mechanism will take over, and because the patient basically is normal. This is only dilution problem which has got the issue. So you manage them for that time, and then you take care of this patient. Okay. Now this patient, I'm not going to tell the answer. This is very simple. The 28-year-old lady, history of fever and right iliac fossa pain. The surgeon admitted diagnosed acute appendicitis. Okay. She has a history of puberty menorrhagia and bleeding after dental extractions. Her HP is okay, platelet is okay, PT is okay, APTT is prolonged, and there's increased bleeding time. Bleeding time is 15 minutes. That was very simple. Somebody has to say, tell me the answer. What do you think? I told you, if the patient has got an APTT that's prolonged and the bleeding time is prolonged, what do you do? What do you think? Past history of puberty menorrhagia and bleeding after dental extractions. Say something, no. no punishment is there. You don't even have to identify yourself. You have to think. Unless you go to the torture of thinking, you will not learn. You must think. You are the resident and you are called. What do you do? This is von Willebrand's disease. Okay. Now, why? Because in von Willebrand's, you have a APTT that's prolonged because of factor VIII deficiency. All right. And the bleeding time is prolonged because I told you the glue between the injured endothelium, and the platelet is the one luminance factor. So therefore the bleeding time is prolonged. All right. So in this case, we have to treat the patient with cryoprecipitate or FFP, but normally we don't use cryoprecipitate or FFP nowadays. We use intermediate purity factor 8, that is got factor 8 plus one luminance factor in it, and then you treat that patient with this intermediate purity factor 8, and then you manage the okay, surgery for whatever. Okay. So normally, when you have a bleeding time, and this I think is important because I mean normally now many people don't do bleeding time, but I think it is very important to do because it gives a lot of information. Supposing the platelet is bleeding time will be prolonged when the platelet count is less than a lakh, or sometimes during heparin therapy, or when the hematocrit is low, like very anemia, like 5, 6, 7, like that kind of HB, 20, 25 hematocrit in that. It should not be done in ICU setting where hypothermia or hypoperfusion is there. Their results are unreliable and is a common in ICU setting. So you should not do bleeding time in that setup. Now, supposing you do automated platelet count, normally you are doing platelet count to the counter machine and everybody comes with a report that normally nobody sees the peripheral smear. Okay, you must exclude ETTA because ETTA pseudothrombocytopenia is quite common and patients come with low count 15, 50,000, 60,000, that sort of thing. And you always have to counter check by a peripheral smear to figure out whether that is pseudothrombocytic because normally you send the blood in ETTA and ETTA sometimes will consume the, I mean, there will be fibrin clot formed in the tube itself. So therefore the platelet count will be low and the automatic platelet count will count the balance platelet that are lowish. But actually when you look at the smear, there will be a lot of platelet on the smear. Sometimes a normal platelet count with prolonged bleeding time, I told you, will be seen in person who's got von Willebrand's disease or there is a platelet dysfunction. The platelet count will be normal, but the bleeding time is prolonged. That means patient got thrombocythemia like Glanman or Bernard-Sully or one of those. The qualitative platelet deficiencies is there. And of course, you have patient who's got antiplatelet drugs like aspirin or NSAIDs. They will also have prolonged bleeding, but platelet count will be normal. And sometimes you can also get in calcium channel blockers to take this stuff for hypertension. So these are common things that you have to remember. And normally they say that bleeding, the von Willebrand is quite common. Supposing you take population screening for von Willebrand's disease, it is 1 in 100. So large number of women probably who got say DUB or something like that, maybe having von Willebrand's mild von Willebrand's disease because DUB dysfunctional uterine bleeding. They say normally the bleeding uterine excessive uterine bleeding in the absence of palpable pelvic pathology is a DUB. So they don't know why they do hysterectomy. Large number of women may be having this, but if you look at hospital-based screening, that is patients who got some bleeding disorder, and then you look at their von Willebrand's factor 8 and von Willebrand's histocity and all that, then you find that the incidence is 1 in 10,000. So it is quite common in various populations, one Willebrand's disease. And it's not very rare. But of course, in India, we don't look for this because we don't have the facilities. And normally, von Willebrand disease is related to the blood group. So supposing you take type O blood group, they have about one Willebrand less than about 40 to 50%. So they may have mild menorrhagia in this people compared to the general population. Okay, so this is something, a fun fact about von Willebrand's disease. It's supposed to be quite common. And if you have women who bleed, you have to always look for factor 8 in them and look for Rakoff assay with histocity cofactor and one of these antigen. At least that you have to do to find out if they've got a mild one. Case 3. Okay. The 70-year-old fellow, 74-year-old fellow with a lot of skin bleeds, spontaneous skin bleeds like this, and has hematuria. Okay. So these are the counts. He's got 75-year-old fellow with hematuria, skin bleeds. PTT is prolonged significantly. Common time is normal, platelet is normal. And when you do the APTT mixing 50 to 50, it is getting corrected. 57. What do you think? Think. Normally, when you have a PTT that's prolonged, okay, there's a four things normally in every patient you have to look for. If the patient has got heparin, okay, the fact that this patient has got normal thrombin time proves out heparin. Factor deficiency could explain the symptoms. Okay, either factor 2, factor 8, factor 9, one of those deficiencies could be explaining symptoms. He could have a factor inhibitor. Okay, or he must be having lupus anticoagulant. But lupus anticoagulant won't bleed. Okay. So normalization of PTT. PTT, you see, patient has got a PTT of 109 and a 50 to 50 correction makes 57. That means a deficiency, is it not? So normalization of PTT means it is deficiency. Can it be lupus? Lupus anticoagulant won't correct with APTT. Will not correct the APTT. So it's unlikely to be lupus. So it is normally to be some factor deficiency. Now, what factor deficiency could come in a 70-year-old fellow with hematuria and skin bleeds? So you do the correction studies again. APTT, half patient, half control is normalizing. Half patient, half H serum is mildly normalizing sort of. And half patient, half absorbed plasma is not getting corrected. Now what do you think? Factor VIII assay was less than 1%, factor IX was 113%, inhibitor level was 9 Bethesda units, so this is acquired hemophilia. Okay. So this is quite often seen, catches you like a googly. Sometimes you get elderly fellows. So supposing you have elderly persons with this kind of a presentation, you think whether the person has got an acquired hemophilia. In congenital hemophilia, the fellow will have bleeding since birth with the same kind of findings, but this is acquired hemophilia. So this is spontaneous development of autoantibody against factor VIII. Usually there are IgG heavy chains. It is acted against factor VIII procoagulant activity. Not a very common, is rare, and it's difficult to treat and high mortality. So we give steroids, we have to give cyclophosphamide, we sometimes have to give rituximab, all sorts of things. Immunosuppression basically, and it's got high mortality, and majority of people die of infection in this acquired hemophilia. Okay. Case 4. Patient has got this, I think you should know. 40-year-old lady, chronic dyspnea. She has got mitral regurgitation, and she is posted for mitral valve replacement. On examining, you find JFB is elevated. There is tender hepatomegaly. There is no past history of bleeding. On the table, there is continuous oozing. So the surgeon is saying something is wrong. Call the hematologist. So you are on board. So you take the call, and they have done these tests. HB is 10. Fibrinogen is normal because the cardiology fellows do this. Fibrinogen is normal. APTT is mildly prolonged. PT is prolonged, significantly double. Thrombin time is normal. Bleeding time is normal. The patient is on the table, is open, and there is continuous ooze on the table. What will you do? What will you advise? What will be a thought process? Anybody? What do you normally, why do you normally get a tender hepatomegaly and raised JVP in a person with mitral regurgitation? And is a 40-year-old lady. So it's a chronic rheumatic heart disease. Got progressive mitral regurgitation. So now there's a JVP elevated. Prominent A waves, V waves are there. Ventral ejection of fish. Prominent V wave. And so there's congestive hepatomegaly. Okay. Chronic passive congestion of the liver. And that congestive hepatomegaly, you have impaired hepatic synthesis of all the coagulation proteins, and there will be mild DIC. So here, if the person has got continuous oozing, to advise the treatment with the fresh frozen plasma. Now, in this patient, you cannot give vitamin K and all because the vitamin K is basically normal in these people. I mean, 2, 7, 9, 10 is normal in these people, so it really does not correct this. So you have to immediately correct the oozing and control the coagulopathy. and therefore you have to give treatment with fresh frozen plasma, right? This again you will get called 70-year-old male. He has got transurethral resection for prostatectomy, TURP. After the TURP is done, there is excessive bleeding from the bladder. There is oozing from the IV site. He is moderately hypotensive. HB is 9.9, platelets are normal. Fibrinogen is normal. PT is mildly prolonged. APTT is prolonged. TT is prolonged. All PT is prolonged. PTT is prolonged. TT is prolonged. What do you think? How do you interpret this? Nobody's talking. I sometimes get worried if people are not talking or there's something wrong with my system. I'm just speaking out of the computer. I don't see. Think no. Okay. So normally coming back to the same thing, you took whether some patient has got hypophosphatemia, dysphosphatemia, heparin, liver disease, systemic hyperfibrinosis. These are common things that you want to look at. Can it be DAC? It can't be a hypophosphatemia dysphosphatemia because fibrinogen is normal. Heparin, that you will get by history, unlikely to be heparin therapy. Liver disease, 70-year-old fellow, could have picked it up preoperatively. Is it DIC? Unlikely with DIC because platelet is normal. Okay, and the person is bleeding. So this is a fibrinolytic state. When they do the TURP, there will be a lot of urokinase released into the circulation. So the fibrinolysis is high. And this fibrinolysis is also high in, say, for example, in persons who got oropharynx or endometrium. When you do manipulation in oropharynx or endometrium, there is a lot of fibrinolysis either in saliva or in the endometrium, and therefore there will be bleeding. So this is a fibrinolytic state. So therefore, in persons who got menorrhagia, you can give them anti-fibrinolytic agent like tranexamic acid or epsilonamic caprylic acid and all to control the bleeding because it's a fibrinolytic state. Similarly, in urokinase, a lot of high urokinase is there during the manipulation of the prostate surgery. So it's a fibrinolytic state. So you have to treat them. Okay. This is a little problem case. Okay. 30-year-old lady with pulmonary hemorrhage. Okay. Platelet is normal. PT is normal. APTT is prolonged. Common time is normal. Only APTT is prolonged. What do you think? No, time is getting over. Okay. So heparin is unlikely. Heparin, no, because APTT can be prolonged because of heparin, but heparin is unlikely because common time is normal. Factor deficiency could explain the symptoms because PTT is prolonged, so it could be factor 8 or factor 9 or factor 11 deficiency. Unlikely because she's a lady. Normally you get it in men. Don't get factor 8 or factor 9 deficiency in women. Okay. And factor 11 deficiency is rare. So you would not think of factor deficiency. Can be factor inhibitor like acquired hemophilia. Unlikely because they won't come with that age usually. Could be, but you know, a bit unlikely to have factor inhibitor acquired hemophilia. What about lupus anticoagulant or other factors like FEL, high molecular weight canadian nucleic? They don't cause bleeding. They can cause abnormal APTT, but they will not cause bleeding. This lady has come with pulmonary hemorrhage. Okay. So you go ahead and do the mixing study. Okay. So you do a mixing study, 50-50 mix, there is no correction. When you do DRVVT, it is prolonged. Dilute Russell Vapor Valentine is prolonged. Dilute Russell Vapor Valentine mixing study, there is no correction. So this looks like an autoantibody to phospholipid binding protein. It prolongs the APTT and acts like an inhibitor in mixing studies. So this is a lupus anticoagulant. But the point is, lupus anticoagulant, though it is confirmed by laboratory testing, will not explain the pulmonary hemorrhage because lupus anticoagulant is a misnomer. It is not anticoagulant. It is normally associated with thrombosis. Okay, like APLA, antiphospholipid antibody. They produce thrombosis. They don't produce bleeding. Okay. So what do you think this lady has got? Pulmonary hemorrhage. So what we did is we did a bronchoscopy, and there was a vascular malformation as a source of bleeding. Okay, we also got stung with this. So we corrected the muscle. So this incidental finding, LA lupus anticoagulant was incidental finding, and hemorrhage, pulmonary hemorrhage was independent of the prolonged APTP. There was no need of correction of APTP necessary, and the vascular malformation, they did embolization and closed vascular malformation. So sometimes you get googly like that. So you have to, I think this is the last case. Okay, so this is a 36-year-old male. He has had 3 episodes of DVT from 2017 to 2002. Sorry, 22 should be. Okay, 17 to 22. There's an error there. Patient was hypotensive on treatment. HB is normal, TC is normal, platelet is normal, mild thrombocytopenia, AN is negative, mild thrombocytopenia, PTT is prolonged, half patient, half control, gets corrected. Lupus anticoagulant is positive, anticardiolipin antibody is negative, mild renal failure, urine proteins are 1.1 grams per 24 hours. This is the scenario. All right. This patient needs renal biopsy. What is the risk of bleeding in this patient? What measures you have to take to prevent bleeding? And if the bleeding is severe, what can be done? Anybody? See, there are no right. You have to. This is the thing that you will get normally as a consultant, as a PG resident. So you have to know what decisions to take. Your nephrology resident will call you saying this is the values. PT is normal. PTT is prolonged. Platelet is normal. Lupus anticoagulant is positive. Anticardiolipin antibody is negative. Mild renal failure. Nephrotic range proteinuria. Some proteinuria. And the person needs renal biopsy. Will you do it? Will you not do it? What do you advise? And if you do it, what are the risk of bleeding? What will you tell to prevent bleeding? And if bleeding is severe, what you should do? Ten minutes more. Okay. Just think, okay? Just think, because there's no time, I think. Okay, so what they did was they were not able to take a decision. Okay. So the patient was started on steroids, 1 mg per kg body weight without a biopsy. Okay. Then what happened? They returned to the emergency 2 weeks later with acute dyspnea, altered sensorium, and a platelet dropped to 20,000. Okay. Now, this patient has an infarct. All right. So now this night, and this fellows come middle of the night. The emergency fellows have called you, and they have told you this is what has happened. So what do you do? So you have to take a call whether your patient needs anticoagulant despite thrombocytopenia, or whether you think that thrombocytopenia will protect against the development of thrombosis, or leave him alone. Is that feeling justified? Is that impression justified? Anyway, he's got thrombocytopenia, he's a bleeder, so why bother? Don't give him anticoagulant, don't give him heparin, don't give anything. Is that the can we do that? Is it justified? Just to tell you, the thrombocytopenia does not protect against development of thrombosis. It may be associated with increased risk, for example, APLA, antiphospholipid antibody, heparin-induced thrombocytopenia, and DAC. And the highest risk of thrombosis occurs when there's a more than 90% fall in the platelet count. So if you look at these papers and look at critical features of patients who develop thrombosis in the ICU, large number of people, 60% of patients develop thrombosis when the platelet fall is more than 50% of its basal value. All right. But the highest risk of thrombosis occurs when there is more than 90% drop in the platelet count. So thrombosis, the thrombocytopenia does not predict thrombosis. In fact, when the drastic drop in platelet count, then you think of. Okay. Now there are various guidelines that say that for patients with acute or non-acute VTE, thromboembolism, you have to stop anticoagulation if the patient's count is less than 20. All right. So, okay, so we'll not give anticoagulation to this patient. So what will you do? You've got thrombosis, the brain, venous infarcts, old case of recurrent DVT, platelet is low. So the recommendation is if the platelet more than 50, give therapeutic dose of low molecular weight. 30 to 50, give reduced dose. Okay. And platelet less than 30, you discontinue therapy. So this patient, just to remind you that is a 30-year-old male, 3 episode DVT, VT, and a CVT, thrombocytopenia 20,000. All right. So what we said was they give transfusion to maintain the platelet 50,000, and then initiate there is a therapeutic dose of anticoagulation with heparin. Now, how do I get that platelet to that elusive 1 lakh number to give him good anticoagulation? Will give him steroids, will give him IVIG, will give him TPO. 3 options, no? Anyway, he was on steroids, and despite steroids for that renal problem, he developed thrombocytopenia. So steroids may not be a good option in this fellow because he's already on steroids. That leaves you only to IVIG or TPO to increase the platelet to 1 lakh. Okay. So anybody? This is real case, huh? It's not from the air. So this paper came in last month, okay, 2023, and they said that if you take, they described their experience of TPOs, and they said TPO can actually, thrombopoietin agent, okay, can actually cause catastrophic antiphospholipid antibody, and it's got a side effect of L-thrombopathy. Okay, so this paper came just last month. I was not aware of this. What I did was, I based my therapy based on these 2 papers. Then they said you can actually increase the platelet count in perioperative thrombocytopenia. Romplastin is good. And the other paper was there, the use of high dose altromebag in treatment of sepsis-related thrombocytopenia in critically ill patients. And this paper was 2019, and the other one was 2018. So I said, okay, there's some literature on that. So we put the patient on TPO. Okay, we started the patient on L-thrombopag, 50 milligram twice a day, with improvement of platelet count to 1.8 lakh to 2 lakh within a matter of 10 days. And then we started on low molecular heparin. But actually, we should have given him IVIG. That would have been better because this paper came just last month, and I was not aware that we should have given him IVIG, but IVIG was costly and all that. So there was issues with that. So we give our patient this and manage with that. But sometimes, you have to take a call. There's only anecdotal case report. You take these cases, there are only 2 cases that they have described, and they are calling it as possible precipitation of catastrophic antiphospholipid antibody syndrome. So this is the paper, but you have to be careful that when you have patient with thrombocytopenia and thrombocytosis, you may worsen the thrombosis by giving L-thrombopag. So you have to be cautious about it. And supposing there are more and more case reports, then you will know that there's a definite no, but otherwise it still can be. So just the last slide, 4 or 5 minutes more. So laboratory results aids in diagnosis, but it's a clinical history that defines the diagnosis. So you have to take the history, and based on which history you take, you decide what the problem seems to be, and you interpret the test based on history, and then do the physical examination. Okay, do the laboratory testing. So that is the last slide. And so, if there are any questions, Chat box, there are some. What is the cutoff for APTT correction? There is a question. What is the cutoff for APTT correction if it is required to completely correct? No, no, no. It's not required to completely correct. More than 50, more than half the correction is more or less okay. Like I showed you one case now where the PTT corrected about the normal was 109, APTT was 109, the correction was 87. That's okay. It shows that it's correction, right? Okay. Platelet dysfunction. I don't know what that is. Okay, maybe that patient has got bleeding time is prolonged. Yeah. Impending DIC, low hematocrit, dilution coagulation. Yeah, somebody's answered. Then you could have said no. Okay. State. Okay, that's correct. That may be the one Wilson's disease. Okay, TEG or ROTEM to decide. Yes, TEG and ROTEM. But the point is, TEG and ROTEM is not easy to get, not available on. But of course, cardiology fellows, cardiac fellows that have that TEG or ROTEM, not freely available. Okay, so that one is not possible. That's also correct. Okay, so one Wilson's disease. Okay. Okay. Yeah, you got actually answers there, but you can say actually, no, otherwise I'll not know. Okay, one Wilson's disease. Okay, correction studies. Okay, acquired study heart failure actually, but that you are not told why the coagulopathy, you know. What is the diagnosis last case? Most probably because the ANA was positive and the recurrent DVT, you would have a lupus nephritis. 20-year-old known as chronic ITP and non-plastic absent developed acute DVT lower than now PFX 22 management. Yeah, what do you think? We have to give, I think the safer thing is to give IVIG if the person has got bleeding. And then 28-year-old female known as a chronic ITP, okay, IVIG on non-plastic dapsone, tell acute DVT. The platelet is 22. Yeah, you have to give IVIG and put the patient on heparin for acute and then managing chronic. You have to rule out ITP means you have to rule out associated lupus anticoagulant. Normally, ITP primary will not cause LA positivity. If the person with ITP has got thrombosis, there is accompanying lupus anticoagulant. That means becomes a secondary ITP. So you have to do a lupus anticoagulant or an anticardiolipin antibody and find out if the person has got an associated antiphospholipid antibody, because thrombocytopenia is seen in patient lupus anticoagulant with thrombosis. Okay, so these people will have recurrent abortions, DVT, and so on and so forth, a low platelet count. Precautions in sending factor VIII inhibitors level. Yeah, so this would be a single drawn blood gene venipuncture in the blue top tube, the correct 9:1 ratio, and send it immediately, and they will process the thing to the test. Right. Then can we switch to TP of no response? One, I have not seen. I mean, can we switch TPO from ROM plasmid to L-ROM pack is what you're saying. I think there's nothing much to choose between the two. Depends on availability, cost, and so on. I don't think there's much to choose between the two. Both are okay. What is secondary TTP? Okay, secondary TTP is a TTP associated in bone marrow transplant setting in GVHD or patients who got cancer, colon, or some malignancy, mitoxanthoma, one of those things which are called secondary TTP. Okay, otherwise the TTP will be no cause found as the primary TTP. How much in second prolonged NPT needs evaluation in asymptomatic patients? So normally in our laboratory, if it's more than 6 seconds, more than 6-7 seconds, we consider take it seriously, because then you have to ask the laboratory when the APTT testing that they do is a lupus sensitive APTT reagent or a normal APTT reagent. So the laboratory will tell you that ours is a lupus sensitive APTT that they use, and then you think that could be normal. But supposing they're using the normal non-lupus sensitive APTT, then that means it is a factor deficiency you have to really look for. What is the cutoff For the control, we take PT. That will be depending on normal. What is the cutoff from the control? We take PT or APTT normal. That will depend on laboratory. Every time you do a APTT or a PT, you will have a control that the laboratory does. So sometimes the PT control is 12 seconds, 13 seconds, 15 seconds. And therefore, in patients PT, you have a INR, which is normalized depending on the oral anticoagulant. So that is a different thing. Now, supposing you are using APTT and the lupus anticoagulant sensitive APTT reagent, okay, it will differ. So normally we would take more than 6 or 7 seconds from the control of that patient. That laboratory will tell you whether your APTT for that during that day was 13 seconds, 14 seconds, 15 seconds with the control. Therefore, you always run a control with the. So that is the last question. Any questions? Any more? I think I answered all the chat box questions. Good. I thought nobody answering. You can say no. I don't know whether you are muted. Any questions? I think you have 2-3 minutes more. I think 8:03. We started 8:05. Manufactured control is better or mean of population sample. I'm not too sure whether you will get manufactured control, because I think control is what you do in your laboratory. I don't know whether you get manufactured control. I do not know. It's what we normally do in our laboratories. You have a group that, because you normally have your own laboratory controls. You have a commercial control value and you have a normal control, and then you also look at and find out in your laboratory what your control is. So that you have to ask your laboratory how the controls are made. Okay. I think normally supposing we see the manufacturing control in the laboratory is very costly, and so they have a control and they have an internal quality assurance in any laboratory, and they are accredited laboratory to the World Federation or some EQUAS program that is there in the laboratory, and they will have a value that they constantly keep checking the controls. Manufacturing control or population control, your laboratory will take. How do you manage the renal biopsy associated bleeding in that case? Oh, we have to give IVIGG and ideally, as per that other paper that I showed you, you give IVIGG and hike up the platelet count, and then you do liver biopsy, the kidney biopsy in that patient, because the platelets are low. Okay, in that case. So in that, the other thing is whether you can use TPO, but then that paper, that two papers I said just came last month. I was a little surprised. I would still give romiflostin or Helcomapag and hike up the platelet and do the biopsy. Yeah, it was APL. Yeah, the young male fellow was APL because he had recurrent DVT. LA was positive. Lupus anticoagulant. Lupus anticoagulant was positive, but the anticoagulant was negative. NA was positive. So it is APL. And then that's the issue. That's why I showed you that paper that came in medicine, where a TPO is associated with catastrophic APL. So that's based on 2 cases. But I think that's anecdotal. If you ask me, I would have given TPO, one of those romiflostin or Helcomapag, and got a platelet too, because that's what we did in that other patient. We hiked up the platelet, and that platelet from the 1.5 lakh, then 2-3 days later maintained at 2 lakh, and then we went ahead and did the biopsy. How to correct sample volume in significant lower how to correct the sample volume. So you have to correct it for the hematocrit. The other thing is you have to take less amount of blood, okay, and educate and do the APTT. But the point what I'm trying to drive at is that in patients, especially with congenital heart disease, okay, and we have to have whose HB comes at 20, 19, 18 like that, and the PTT is usually prolonged, okay, and those are even mentioned in the earlier editions of Perloff, where patients with congenital heart disease, they have a lot of coagulopathy and so on and so on, but they don't have bleeding manifestations. So normally what you do is, in those people, you do a phlebotomy, okay, 450 cc phlebotomy you do, bring down the hematocrit and then do the repeat APTT and PT, and then you find that they are corrected. Supposing the person has got 20 HB, how can you correct in the tube? Can't. So you have to do a phlebotomy, bring the hematocrit to 16, 17, that sort of thing, because these fellows usually in the setting of transient heart disease or OSA and things like that, you have to reduce the platelet count anyway. So that okay. So how to correct the sample of IPC? Okay, so that is what is the immunosuppressive agent? Is what immunosuppressive agent is preferred in patient not responding to steroids and ITP? So normally we give immunosuppression with simplest thing is azathioprine. We give cyclosporin. We give MMF, mycophenolate, and in patients who have got very low, dangerously low platelet count in ITP, we give IVIG. So those sort of things we give. Depends on the intensity with which the rapidity with which you want to say. For example, a patient has got pregnancy and the person has taken up a cesarean section or delivery, normal delivery. You don't want the platelet to be a 10, 20,000 on, so you do IVIG, that's it. On the other hand, a patient got 20, 30,000 and is planning some surgery later on or elective procedure, or person is manual labor, you have got time to increase the platelet to say 50, 60,000. Then you have got azathioprine to give, cyclosporin to give, mycophenolate to give, or TPO to give. One of those TPOs, romoplastin, or you can give endomorphic. That's what we normally do. How to correct the sample? Okay. What immunosuppressive? The platelet count is 9. Yeah, the platelet count drop from 2 lakh to 90,000 will cause thrombosis. That was the problem. Okay. So how long to continue romoplastin patient to respond? Oh, that see, now there are some studies that are there that tells you that if you give, say, a patient who got difficult to treat from an ITP, and you give them, say, 3 months, weekly once romoplastin for say 2 to 3 months. At the end of 3 months, quite a few people go into remission, maybe for 5 years, 6 years, like that. So long-term remissions are possible when you use romoplastin for more than 2 months, 3 months, like that. So normally we would recommend giving romoplastin once a week, 4 weeks plus 4 weeks plus 4 weeks, 12 weeks, and then you leave them alone. So once you do that, the remission status will be quite 2 years, 3 years, 4 years. Now supposing you give romoplastin and the platelet count goes from 56,000 to 1 lakh, and then you stop it, again it comes down. Then you know it is you're treating it as a low-lying fruit. You're just treating it on demand. Not good. But supposing you want to get a lasting remission, you can counsel the patient to say that, okay, if you give a long-term, longer period of romoplastin, the chances of you getting to a longer period are high. 70-80% of patients on prolonged treatment with romoplastin will go into a longer period of remission. These are difficult to treat ITPs, so you can counsel them short of giving splenectomy. What is the preferred immunosuppressive treatment in ITP who failed first line? Normally, I give cyclosporin, takes 2-3 months to act. Can give mycophenolate, again takes 2-3 months to act. If it doesn't act, then you have to give one of these newer TPOs. Earlier, we used to give vincristine, cheap drug, and patient can't afford all this. You can give vincristine weekly once for 4 weeks and see. Okay, no response, low budget, cyclophosphamide vincristine 21, like CBP regimen. They give once a month, couple of months, and see if it responds. This is a low budget. Supposing the person has got enough of resources, cyclosporin and mycophenolate and TPO. Elderly patients present with IC bleed and no apparent cause, and normal coagulation assay, fibrinogen platelet count, no other significant bleeding history. This one is elderly. Okay. Do we look for acquired causes or congenital causes? What would be the next clinical choice? So in this patient, if he's got a IC bleed, normally factor 13 deficiency. Okay. If they are mild factor 13 deficiency, they normally have near normal life. But supposing in the elderly, in the factor 13 or other atherosclerotic disease and other degenerative diseases occur, they may have IC bleed. So I would like to look at if you rule out trauma, if you rule out alcoholism and rule out other issues, common issues that are there causing IC bleed, and it's unusual IC bleed, then you have to look at factor 13 and see whether that factor 13 is low. Normally, for factor 13, you do a 5 molar urea concentration and see whether the plot is stable or not. It's a simple test to do in the laboratory. But that is sensitive to moderate to severe disease. Okay, supposing you have got a mild factor 13 deficiency, you actually have to do an assay, because if you are actually diagnosing mild factor 13 deficiency, that means you can prophylax him so that you won't develop an ICB. So it is important to do the factor 13. Otherwise, if he has got spontaneous IC bleed and the PT is prolonged, repeat the PT and C, PTT and C. But I would, if the PT is normal, you are saying that elderly fellow with normal coagulation assay, I would like to do out factor 13. Can we give 2 oral immunosuppressants? Yeah, sure. We give cyclosporin and azathioprine. No problem. You can give, but usually you don't give cyclosporin and mycophenolate, but you can give azathioprine and mycophenolate, azathioprine and cyclosporin, no problem, because they're acting in 2 different role of emicizumab in acquired hemophilia. Oh yeah, this actually is we have used it. Okay, it works wonders. You know, it controls the bleeding, and we have used it in 3 or 4 patients, and remarkable improvement in emicizumab and then afterwards we figured, because this is not anything great science, we had this patient acquired hemophilia who was in ICU, was bleeding away. We gave him emicizumab, perfectly fellow became normal and recovered from all his bleeding problems, and then he died subsequently of sepsis. So these people acquired hemophilia, you can control the bleeding problem, and once the bleeding problem is controlled, you have to make sure to see that they don't develop infection, because these fellows, some or the other, a large number of people die of infection, not of bleeding. So when the person has got bleeding, we have given emicizumab and it works very well. No issue at all. For acute bleeding, I mean, supposing the person has got hematuria or hematemesis or something, IC bleed, you can give emicizumab. Yeah, no problem at all. We have used that. No, this is acquired hemophilia. Okay, the question is, acquired hemophilia started on emicizumab, presently doing good, but till when we should continue? See, emicizumab you can give, because that one shot of emicizumab will work for 2 weeks, 3 weeks, like that. And some people it works even for 6 weeks. One single shot of 105 mg of emicizumab works for 4 weeks. So as long as the patient not bleeding, and this patient usually with acquired hemophilia will put on steroids or cyclosporin or cyclophosphamide or one of those immunosuppressants you put. Once the PT becomes normalized, you can stop the emicizumab. And then you have to see that basically you should give them liberal with antibiotics so that they don't get infection, and screen properly for the UTI or pneumonia, URT and things like that, to see that they don't get things. I would be more concerned about immunizing them with some pneumococcal vaccine or one of those H influenza vaccine, and give them amoxicillin or ampicillin or one of those simple antibiotics to see that they don't get infection, and prevent, advise them about neutropenic. What normally we advise for neutropenic: keep your oral hygiene clear, good oral hygiene, good anal hygiene, and things like that, and see that they don't get infection. And they usually within 6 weeks, 8 weeks, they're normal. You don't keep on giving them, emicizumab, and if they recur, then you treat them episodically. Yeah, we have also had quite a few patients. We have given emicizumab. Then they do well. Actually, 105 single shot.